My name is Dr. Dana Chase. I'm a associate professor in the Division of Gynecologic Oncology at the UCLA David Geffen School of Medicine in Los Angeles, California. So we know that tumors are typically enriched for one or more molecular alterations. These alterations are found across a variety of cancers and are likely to predict a response to therapy. The term tumour-agnostic or pan-tumor approaches involve tailoring treatments based on a patient's molecular profile rather than histologic classification and tumor site in an effort to optimize treatment outcomes. Now, this approach to treatment signals an important new paradigm in the clinical management of many different solid tumors, and there's a shift towards, because of these pan-tumor or tumor-agnostic approaches, there's a shift towards personalized oncology treatments rather than perhaps tumor-specific treatments, just personalized oncology treatments in general. So we've had several tumor-agnostic approvals over the past few years, targeting a range of molecular alterations. And this has really transformed the way we treat different solid tumors, mostly in the advanced metastatic and/or recurrent settings. You know, the first tumor-agnostic approval granted by the FDA was for the anti-PD-1 monoclonal antibody called pembrolizumab, and this was back in 2017. As you know, pembrolizumab was approved for unresectable or metastatic tumors that are microsatellite instability high, or MSI high, or DNA mismatch repair following progression on a previous treatment. And we know DNA mismatch repair proteins can be mutated and signify response to these anti-PD-1 monoclonal antibodies like pembrolizumab. Pembrolizumab was approved based on the prolonged and pretty significant responses observed in 14 different tumor types across 5 different keynote studies. And since then, pembrolizumab has also been approved for patients with high tumor mutational burden called TMB. Dostarlimab, which is another anti-PD-1 antibody, also became available in 2021 for recurrent or advanced solid tumors with DNA mismatch repair following positive outcomes on the phase 1 Garnet trial. So since then, since those anti-PD-1 tumor-agnostic antibody approvals, there's been a number of targeted therapies, including tyrosine kinase inhibitors, antibody drug conjugates that have also received approval in tumor-agnostic or pan-tumor indications. For example, there's several drugs, such as entrectinib, that are indicated for patients with NTRK gene infusions, which may occur at a high frequency in some rare solid tumors. So for patients with BRAF V600E mutations, a combination of the BRAF and MEK inhibitors is approved based on positive outcomes seen in adults and children across multiple solid tumor types. The only caveat here is it's not approved for patients with colorectal cancers because of known resistance to BRAF inhibition. Another example of these pan-tumor or tumor-agnostic indications is patients with locally advanced or metastatic RET gene fusions who've progressed on or following prior systemic therapy and now have a treatment option as well. And so there's a tumor-agnostic approval for a drug based on efficacy and safety outcomes from a basket trial. And most recently, and perhaps why we're so excited to talk about this today, is that we saw the first tumor-agnostic approval for the antibody drug conjugate trastuzumab deruxtecan. And this is for patients with solid tumors expressing high levels of HER2 who have received prior systemic therapy and have no satisfactory alternative treatment regimen. And this approval was based on positive efficacy outcomes across 3 different trials: the Destiny Pan-Tumor 02 trial, the Destiny Lung 01 trial, and the Destiny CRC or Colorectal Cancer 02 trial. The oncogene ERBB2 encodes for the receptor tyrosine protein kinase ERBB2 or HER2 and plays a critical role in cancer development and progression. HER2 actually has no known ligand, and HER2 is activated via a heterodimerization with other HER family receptors like EGFR or HER1 or HER2 and HER4. It may also form homodimers when it's highly expressed. HER2 can increase the activated HER protein's affinity to ligands, affect the stability of the receptor, and induce the amplification of the HER2 signal cascade. HER2 protein overexpression or amplification has actually been well described in breast cancer and other cancers. And occasionally it's mutated, most frequently because of insertions in exon 20 in various solid tumors such as non-small cell lung cancer. While alterations in HER2 are observed more often in some solid tumor types, such as breast, colorectal, gastric, and non-small lung cancers, the need to address these alterations in other cancer types does still arise, and it's important that we're able to identify and target them. Alterations in HER2 occur in many solid tumor types and actually have significant implications for patient outcomes. For example, HER2 overexpression is associated with an aggressive phenotype, poor prognosis, increased risk of recurrence, and limited benefit from traditional chemotherapies. Overexpression has been observed in a range of solid tumors, including breast, gastric, biliary tract, bladder, pancreatic, and gynecologic cancers. HER2 amplification is an important alteration in certain solid tumors, particularly breast and gastric cancers, where it's associated with a shorter disease-free and overall survival. And while HER2 mutations occur in a relatively small subset of patients with non-small cell lung cancers, like less than 5% of these cases, they are clinically significant and are associated with more aggressive disease courses. We now have evidence demonstrating the benefits of HER2-directed therapy in solid tumors originating in specific sites, which supports the rationale for using tumor-agnostic approaches in patients presenting with HER2 alterations across multiple tumor types, particularly in patients with metastatic, advanced, or recurrent situations. Some examples of where we've seen these site-specific benefits are in HER2-positive and low metastatic breast cancers, HER2-positive locally advanced or metastatic GE junction or gastroesophageal junction adenocarcinomas, and HER2-mutant non-small cell lung cancers. HER2 is also an emerging biomarker in other solid tumor types, such as HER2-positive biliary tract, bladder, cervical, colorectal, endometrial, ovarian, and pancreatic cancers. So testing for HER2 varies based on the detection of mutation, amplification, or overexpression, and varies across or according to different tumor types. HER2 mutations can be detected through broad molecular profiling, like next-generation sequencing, which is the typical way of looking for HER2 mutations. And it's recommended in certain cancer types, such as non-small cell metastatic lung cancer. Most next-generation sequencing, or NGS panels, do tend to include ERBB2 mutations. However, clarity over the type of mutations is required to further inform treatment decisions. Amplification, on the other hand, is most frequently tested using FISH, while levels of HER2 protein expression are detected using IHC or immunohistochemistry assays and scored accordingly. So it's really important to understand that you can test for amplification, but you can also test for protein expression, and that these are tested using two different modalities. Based on the current scoring system, an IHC value of 0 or 1 plus technically means the patient is HER2 negative. IHC testing for and results returning as IHC 2 plus means equivocal, and then FISH testing is needed for future or further clarity. But IHC 3 plus is technically a HER2 positive tumor. It doesn't require any kind of confirmation or additional test. IHC testing is actually the most commonly used method for the clinical classification of HER2-positive tumors, and it's essential for these tumor-agnostic treatment approaches or purposes. So this has been difficult, I think, for the general medical oncology community to understand and adopt. Determining a patient's HER2 status is needed, of course, to determine if they're eligible for HER2-directed therapy. Yet there is a major challenge with establishing HER2 status, and there's mostly because there's a lack of standardized testing protocols, and many treating oncologists don't necessarily understand their institution's testing protocol. And so this means the interpretation and application of the findings can vary across providers or even across centers in the same city. So CAP and ASCO have issued specific guidelines for HER2 testing in both breast and gastric cancers. But there really is a need for similar guidance across other tumor types. Like, for example, in the gynecologic space, we're really kind of unsure if our center is using breast or gastric, and or which testing protocol is most appropriate for our gynecologic cancers. On top of that, there is still a lack of consensus around definitions of HER2 positivity, with variability in scoring and interpretation of HER2 status, again, which makes it challenging to know which patients should actually receive this HER2-directed therapy. For example, the immunohistochemistry classification system, or the IHC classification system, may not be applicable across all tumor types because of variability in expression levels and limitation of the currently approved assays. So is the breast scoring or the gastric scoring appropriate for our gynecologic cancers? That's kind of something we still need to develop. And we still can't be certain that IHC testing is sensitive enough to consistently detect the lowest level of HER2 protein. In other terms, whether IHC 0 or 1+ truly means that no HER2 is present, that kind of remains to be defined. Although HER2-directed therapies are predominantly indicated for patients with expression levels of IHC 3+, recent studies have shown us that patients with lower HER2 expression levels, like a patient with 1+ or 2+, potentially may also benefit from these therapies. So the first approval of HER2-directed tumor-agnostic therapy came earlier this year, with the FDA approving trastuzumab deruxtecan in patients with HER2-positive, defined as IHC 3+, solid tumors who've received prior systemic therapy and have no satisfactory alternative option. This was a really exciting pan-tumor or tumor-agnostic approval. And FDA approval was granted based on the efficacy outcomes of this very important DESTINY-Lung01, DESTINY-CRC or colorectal cancer 02 trials, as well as for the gynecologic space, the DESTINY-PanTumor02 trial, where tumor-agnostic activity was actually demonstrated across tumor types like biliary tract, bladder, cervical, endometrial, ovarian, pancreatic, and other perhaps less commonly discussed tumors like salivary gland cancers. And of course, in this trial, the greatest benefit was in the IHC 3+ cohort, although as I've said previously, we saw interesting responses in the 1+ and the 2+ patients as well. In the DESTINY-PanTumor02 trial, specifically in the IHC 3+ cohort, we saw an objective response rate that was 61.3%, with a median duration of response of 22.1 months and a median PFS of 11.9 months, as well as a median overall survival of 21.1 months. And I will emphasize here, these are patients that had previous treatment. So these are recurrent, sometimes heavily pretreated patients. In the overall cohort, so now including not just the 3+ cohort, the objective response rate was 37.1%, with a median duration of response of 11.3 months, a median PFS of 6.9 months, and a median overall survival of 13.4 months. It's important, of course, to mention, despite these pretty remarkable responses, it's important to mention common adverse reactions or adverse effects of these drugs. And so across studies, some of the common adverse reactions include changes in blood parameters, increase in liver markers, and of course, gastrointestinal symptoms. Clinicians should also be aware of the risk of interstitial lung disease and potentially also embryo-fetal toxicity. Now, I will say that interstitial lung disease with trastuzumab deruxtecan is not an extremely common side effect or adverse reaction, but one that you really should be aware of and monitor for. So overall, and just to summarize, the results from these studies and the subsequent approval of trastuzumab deruxtecan has meant that for patients with a range of HER2-positive solid tumor types, which include rare and difficult to treat cancers that often lack standard first-line therapies, we now have a very exciting treatment option. The significance of this approval has already been demonstrated by the fact that clinical guidelines, such as those for HER2-positive gynecologic cancers, have begun incorporating trastuzumab deruxtecan into treatment algorithms. So, for example, in the gynecologic space, we're really discussing now the HER2 status of all three of our most common tumors, like cervical, endometrial, and ovarian cancer, during our tumor boards and our discussions with patients about treatments to use.